Welcome to Oncology Data Advisor. Today we're having a Fellows Forum interview, and I'm joined by Dr. Matt Hadfield. Thanks so much for coming on today.
Thank you so much for having me.
To start off, I'd like to share a little bit about yourself and what you do in your work.
Yeah, so I am a third year Hematology Oncology Fellow at Brown University in the Legarreta Cancer Center in Providence, Rhode Island. I predominantly do research in early phase clinical trials. So these are clinical trials that are often first in human studies with an emphasis on novel immunotherapy medications as well as immunotherapeutic combinations to overcome resistance and focus predominantly on solid tumors. And throughout my fellowship and even residency, I've developed a really profound interest in immunotherapy toxicities, which I think is something that is very relevant to not only practicing oncologists and hematologists, but all practitioners of medicine. So those are kind of my big areas of research and interest.
Awesome. So to delve into your research a little bit, what exactly is immunotherapy and how does it differ from chemotherapy or targeted therapies?
Yeah. So immunotherapy has really changed the landscape of how we treat cancer. The concept that we could harness the body's immune system against cancer really goes back, you know, all the way to the turn of the 20th century with something called Cooley toxins. So physicians back then would notice that patients who had co-infections with sarcoma would actually do better in terms of regression of their tumors, which led to this hypothesis that the immune system played some type of role in controlling cancer growth and proliferation. And in the 80s and the 90s, we used to use something called interferon pretty frequently, which essentially stimulates innate immune responses and was horrible. It really led to lots of systemic toxicities. People felt like they had the flu all the time. It was really not easy to tolerate, and you know in addition to not being easy to tolerate, it also had very poor responses in terms of treating cancer, particularly melanoma. And then, Jim Allison, who won the Nobel Prize back in 2018, he spent most of his career working on something called CTLA-4, which is an immune checkpoint. So basically, the immune system, is wonderful when it works the way it's supposed to, but we have these breaks built in place called checkpoints that stops the immune system from becoming, too overactivated, too proliferative, and essentially stops autoimmunity. And what Jim Allison, as well as his collaborators in Japan, discovered was that these immune checkpoints could be blocked and then allow the immune system to then turn T cells against cancer and treat it as a treatment modality. The first approved immune checkpoint inhibitor was ipilimumab in 2011 for metastatic melanoma. And just to give a little context to how bleak melanoma was prior to that, we used to give, as I mentioned, interferon and dacarbazine, and the overall survival back then for patients was less than a year. With ipilimumab alone, the overall survival increased to just shy of 3 years. And then with the combination of two immune checkpoint inhibitors, nivolumab and ipilimumab, which nivolumab targets another immune checkpoint called PD-1, the overall survival is now over 5 years, which is remarkable considering where we came. So immune checkpoint inhibitors turn the body's immune system against the cancer, whereas chemotherapy is really drugs that just indiscriminately kill rapidly dividing cells. And then targeted therapy, which is sort of the third box that we kind of think about in terms of cancer treatments, are therapies that target specific proteins or genomic alterations that are driving the cancer. So immunotherapy has now had dozens of FDA indications across multiple solid tumors and hematological malignancies, and has become really an absolute, remarkable advancement in the field of oncology, and provided durable benefits to multitudes of patients.
Awesome. It's really remarkable to, hear about those results. And thanks so much for, comprehensive overview of them. So I know that a lot of your research as well focuses on the management of immunotherapy-related adverse events. So what exactly are these and how do they differ from known toxicity from chemotherapy?
Yeah, I think that, that's a really important question right now as we start to give more immunotherapy across the board to lots of different types of cancer. When we think about chemotherapy, it really is drugs that are designed to kill rapidly dividing cells and has a very predictable pattern of toxicities. For instance, when you give chemotherapy, you can expect things like nausea, vomiting, hair loss, GI side effects, cytopenias like anemia, thrombocytopenia, things like that, that all are very predictable when you think about giving a drug that attacks rapidly dividing cells. Obviously, every chemotherapy has its own side effect profile, but immunotherapy really is a completely different box altogether. So when you give an immune checkpoint inhibitor, what you're doing is you're taking the brakes, so to speak, off the immune system. And when you do that, you can induce an autoimmune reaction in a patient. So in patients who have received dual checkpoint inhibitors, the incidence of grade 3, grade 4 immune side effects is over 50%. So it's a significant amount of patients develop these types of toxicities. Most commonly, you could have inflammation from T cell activation in your lungs, that would be considered pneumonitis, in your colon, colitis, dermatological reactions. Those are the most common, but it really is remarkable that immunotherapy can cause autoimmune adverse events in any organ system of your body. And there's rare cases of things like autoimmune thrombocytopenia, autoimmune uveitis, all sorts of strange side effects. So it really is important, not only for oncologists who manage these patients, to be very aware that these toxicities exist, and have to have a high clinical suspicion for diagnosing them, but also the timing of these types of toxicities is incredibly variable. So whereas when you give chemotherapy, you can expect that someone's going to have side effects within 7 to 14 days, and then they'll slowly get better. That's why we design chemotherapeutic regimens in cycles. Immunotherapy can cause adverse events several months after they last received the drug. So, it's a really important thing for not only oncologists to keep in mind, but general practice physicians, emergency room physicians, subspecialists. Everyone has to have a high clinical suspicion because the pattern and incidence of these types of toxicities is incredibly variable.
Mhm. So, what is the current understanding and approach toward how immune-related adverse events are diagnosed and managed, and how do you personally go about approaching this in your practice?
So the way we diagnose immunotherapy toxicities is it's a clinical diagnosis. So at the current time, we don't have any biomarkers to predict, or biomarkers either to predict or to diagnose immunotherapy related adverse events or toxicities. It's a incredibly important void in the field of oncology right now, is that we don't know who's going to develop these toxicities. There's been some very interesting research done at the Harvard Cancer Center and Mass General recently that showed that certain HLA subtypes can predispose to toxicities. But even in those studies, it wasn't clear. People who had this predisposition, not all of them developed the toxicities. So there's still a lot of room to research this further and figure it out. So really, the way we diagnose immunotherapy toxicities is clinical. For instance, pneumonitis. If someone who's been treated with immunotherapy presents to the emergency department or the outpatient clinic and are having shortness of breath, you go through a typical differential diagnosis for shortness of breath in a cancer patient. Things like infectious etiologies such as pneumonia, pulmonary embolism, and really immunotherapy toxicity becomes something of a diagnosis of exclusion. It can be very challenging, and it can be very much overlap with things like pneumonia. Imaging, for instance, is very non-specific pneumonitis. So sometimes pneumonitis can look like consolidation, like a bacterial pneumonia, and sometimes it can look like patchy infiltrates. Sometimes the radiographic findings can be pretty subtle, but have a patient has significant hypoxia. So this is something that any new symptom, any new physical exam finding, any change in vital signs, we always have to sort of think in the differential diagnosis, could this be related to immunotherapy? In terms of management, that's a really important aspect of this as well, because if you think about immunotherapy toxicities, the whole concept is that we're taking the immune system and we're turning it against the cancer. When we develop these types of immunotherapy-related adverse events, then we have to use immunosuppressive medications to then, stop the patient from having symptoms and reduce morbidity and mortality. But by doing that, we're reducing the efficacy of the intended treatment. So this was actually shown in melanoma. Again, the MGH group published results about a year ago that showed that patients treated with high dose steroids for immunotherapy-related adverse events did have worse overall survival, which is intuitive when we think about the fact that we're activating the immune system and then dampening it with an immunosuppressive medication. So, um, typically once we have a high clinical suspicion for an immunotherapy-related adverse event, such as pneumonitis, we start high dose steroids and then taper those based on clinical response. Um, and that's true for most adverse events for endocrinopathies. So, if someone was to have autoimmune thyroiditis or adrenal insufficiency, we do not treat with steroids. We just treat with hormone replacement therapy because the role of steroids is not helpful. You're not going to save those organs in that situation. Same thing with type 1 diabetes that results from immune checkpoint inhibitors. You just treat as any other type 1 diabetes. You wouldn't treat that with steroids. So it can be very nuanced in terms of the management. One thing that's really important and hopefully we'll see more of in the future are steroid sparing treatments. So things like IL-6 inhibitors or TNF alpha inhibitors or IVIG, things of that nature that could either augment the treatment with steroids or could potentially replace steroids altogether, because we know that giving high dose steroids can reduce the efficacy of treatment. We know that the survival is worse, the efficacy is worse of treatment. So it's a rapidly developing field, and unfortunately, we don't have tons of biomarkers at this point. We don't have good predictors. So it's a challenging area and field to manage.
Great. Thanks so much. That was a really, comprehensive overview again of all the different nuances and considerations that go into this. With all these complexities and everything, what do you think the future of IRAEs will look like and how these will be diagnosed and managed as time goes on?
I think there's several things that hopefully will evolve over the next 5 to 10 years. I think one of the big things will be predictive biomarkers. So there's been a lot of research into this over the last 10 years. As I mentioned, HLA subtyping. So, could you find subsets of patients that are at least higher risk or lower risk so that you can stratify? And this is going to become more pertinent as, we progress with these treatments, because if you think about patients who are treated in the metastatic setting, you have limited options, and unfortunately, they're a terminal diagnosis for their cancer. So toxicity is something that you have to weigh with the risks and benefits. But as these therapies trickle down more into the neoadjuvant setting, so as we give them to patients who are going to potentially have curative intent treatments, either with surgery or radiation, and you think that someone could develop a grade 3 or grade 4 adverse event that could take away their potential, life-saving, life-prolonging therapy, we really need better biomarkers to predict who's going to respond, or not only respond, but also develop immunotherapy toxicities. I think, there's been a few interesting studies looking at cytokine profiling. So both single cytokines like IL-6, whether or not baseline elevations in IL-6 predict for immunotherapy toxicities, or, multiple cytokines together, predicting whether or not elevations with a composite score is something that could predict whether or not someone's going to have a toxicity. So far, those haven't really panned out. So I'm hopeful that we will be better at figuring out who's going to develop these toxicities based on some type of predefined risk stratification score, and b use that information to then stratify. Is the risk too high for them to get an immune checkpoint inhibitor? Should they receive just one instead of two? Or should they really be in such a high risk of toxicity that they shouldn't get an immune checkpoint inhibitor at all? So those are some of the big things in terms of determining who's going to and who's not going to get immune related adverse events. I think in terms of treatment, unfortunately, we're very heavily reliant on high dose steroids. So there's a real risk for patients who develop some type of immune toxicity, like pneumonitis, for instance, to be on steroids for prolonged periods of time, many weeks and months, before they can be weaned off altogether. I think, that's has a whole lot of issues in itself. People being on high dose steroids that can't be tapered off. There's metabolic side effects being on high dose steroids. Um, there's the reduced efficacy that I mentioned from having high dose steroids treat immune checkpoint inhibitors. there's just a lot of issues with that. So hopefully in the future we will uncouple ourselves from being completely reliant on high dose steroids, and we'll be able to, use things like IL-6, IL-12, TNF alpha to treat. But also, I think there's potential that in the future we will combine those up front. So when someone starts an immune checkpoint inhibitor, they will get something like a TNF alpha or an IL-6 inhibitor at the same time that will hopefully mitigate and prophylactic against developing a toxicity. And hopefully, we at that point would have predictive biomarkers or something that can help tell who's going to be at higher risk and could benefit from that type of treatment. So there's a lot to figure out, unfortunately, but it's becoming more and more pertinent every day. More and more FDA indications have led to many more patients than 5 years ago being treated with these types of therapies. There's lots of patients that are going to be seen in the emergency department, primary care physician offices, things like that, who are going to be, you know, developing or showing signs of these types of these adverse events, and the clinical suspicion will have to be very high for a lot of different practitioners. And there's multiple new checkpoints. So LAG3 is now approved in melanoma, and TIGIT's being studied in lung cancer. So there's going to be a lot more of this in the future.
Awesome. That'll definitely be exciting to see all the ways that the field progresses in the next few years, even. To wrap up, any parting words you'd like to share about immunotherapy or IRAEs to kind of, raise awareness about it?
I think that the big thing that I would just hope people take away is that immunotherapy-related adverse events should always be on the differential diagnosis for any cancer patient who's treated with these therapies. And it really does go beyond the scope of just oncologists. So there's a really interesting study that's a little dated now, but it was done at MGH back in MGH has done a lot of work in this area, so they get cited an awful lot. But there was a study that basically showed they polled different oncologists at their center as well as subspecialists, their comfortability with managing immunotherapy-related adverse events. And basically, the gist of the study was that a significant amount of both didn't feel comfortable managing it. So, a toxicity. So, if the person prescribing immune checkpoint inhibitors doesn't feel comfortable managing the toxicity, and the subspecialist, such as a pulmonologist managing pneumonitis, doesn't feel comfortable, someone has to own it. So it really does, go beyond just the scope of oncologists. It's a medical problem that everyone has to think about, and it's going to become much more relevant for everybody in the very near future. It's going to be something that everyone's going to see in any subspecialty, as well as primary care and hospitalists. So I think everyone should have some baseline understanding of these types of toxicities, and always have them on their differential when these patients are admitted to the hospital or seen in clinic.
Definitely. Well, thank you so much for coming on today and talking about all this and, helping to, spread awareness of what clinicians should be on the lookout for. So it's definitely a really informative session.
Thank you so much for having me.